Of Wandsworth CCG governing body. So we are live streamed, so public viewing during this meeting. So we'll turn the camera off if we really need to for some appropriate reason. So we got some apologies from Andrew Neal and Dawn Warwick. Have we got any declarations of interest? That
I think Carol's going to be a bit later.
Oh, Carol's, yes, if the number 57 bus is in operation, she'll be here soon. Thank you. So, any declarations of interest? Thank you. Should we do the minutes of the last meeting, which was our October meeting, because we had a seminar in November? Anything on accuracy, first of all? Nothing forthcoming. Very good. Thank you very much for those, Sandra. And actions. There was the one on PPI, which was just to be taken forward into the planning process.
I've fed that back to them.
Thank you. Good away. And that was the only one. Okay. Any other matters arising there that I may have missed? Very good. Thank you. We haven't got any chair's actions in the last 2 months. So there we go. We're off. So we've got quite a big agenda today. There's quite a lot of strategic stuff and forward planning and some really good content, I think. We're doing the CAMS clinical focus today. So we've got Dr. Coffey back. Couldn't keep away. And Rebecca, are you going? Lucy, are you going to kick off? Thank you.
There's a very brief introduction to the crack team. They're ready to present. Just to say, rightly, child and adolescent mental health services have been a real focus for this government, and has that been demonstrated through their commitment in the CAMS transformation plans and the new funding that's been given for 2015-16. But I think our report showcases what the CCG was doing with local authority and provider partners before that has fed into the CAMS strategy and the plans that we have in place for 15-16 and those that we're now developing for 16-17 going forward.
Again, thank you very much for welcoming me back to the board. What I want to do is try to give you a flavour of the kind of work we're doing on CAMS, but also talk about some of the challenges as well. What I want to start to do is to first of all to say a few thank yous. Because at these events, often someone like myself, as a clinical lead, kind of espouses, the success or the failure of what we've done. But behind, kind of every clinical lead is a management support, and I have very much John Beckles, who's worked with me for the last 12 months, and also Graham Markmell, who's hiding in the corner from Public Health, who again is a key support to what we've done. I'm going to make the assumption you've read the paper, and I'm going to try and take some themes out of the paper and try and bring some of the things in the paper together so you can perhaps understand successes and challenges. We're very fortunate in the NHS that we're given lots of money this year. But as ever, the NHS gives the money in a way which can sometimes be difficult to use. So we're given £591,000 for the next few years. But we were only given our chance to spend it for 15-16 about a few weeks ago. So now we've got the unenviable task of trying to spend £591,000 very sensibly in the next 4 months. But also to spend it in a way where you don't make over recurrent commitments, so you can spend it more carefully in the following years. The money's been split between eating disorders and general CAMS. CAMS is a classic partnership kind of system. So the CAMS kind of partnership that we've formed very much brings together the Commissioners CCGs, the key provider, the Mental Health Trust, but also we've got lots of voluntary sector providers and the local authority and public health. What I'm going to try and focus on is kind of giving you some ideas of what our strategic aims are. Because I suppose a few years ago, the focus was just about how do we get tier 3 services sorted. Tier 3 services are the consultant psychiatrist that you would refer your child to. And a few years ago, the waiting time was very, very high. So, and also patients were being bounced back. So what we've tried to do is have a much more kind of global approach. So I'm going to focus on the things which we think are important in CAMHS and what we've done. What we've been told is that, in fact, probably one of the most important things is parenting. It's not about having an NHS service. If we've got excellent parents in Wandsworth, we will have healthy, robust children. So we know we're going to focus on parenting. Secondly, what we know is most, if not all, children go to school. School has to be a key platform for improving the mental health of our children. Therefore, what we're focused on is improving and expanding and starting school-based mental health services in primary schools and secondary schools, and they're quite different. Thirdly, I want to talk about the actual kind of NHS type services, the tier 2, which is your general services like basic counselling, and your tier 3, your consultant psychiatrist, your consultant psychologist. But also looking at some of the future areas. And the future areas that we've got is very much about transition. That we know when a child hits 18, their move into adult services can be very traumatic, disabling, and can produce a reduction in their mental health. And how we can improve that. What we've tried to do for the parenting, and as you'll see in some of our comments, is that Battersea locality were very helpful, and they started a while back some sort of parenting courses based in general practice. And what we found, in fact, a waiting list grew enormously. So what we've tried to do now is make sure we are doing more kind of sustainable, systematic approach to improve parenting. And you will see in the paper a number of initiatives we've done for kind of under 5s, to make sure we're working with children under 5 and their parents. We've also put in Place to Be, is a voluntary sector running parenting classes in 10 schools. We're extending that to 20 schools in the next 12 months. You'll see the figures of the improvement. Now, it's gone from 93 to 94%. 93% isn't the baseline. Last year we had a 93% improvement in people's questionnaires. Now this year it's improved even further, and people are reporting a 94% improvement in their feeling of comfort about how they handle parenting in their schools. So we're very impressed with Place to Be as a very successful partner in delivering our services. Also, we're working with a number of projects the local authority is funding in the community about extending parenting. And as one of our priorities for the spend for our CAMHS partnership money next year, this extra 591k, a large amount of it is going to be putting in a sustainable parenting support service for our community. The second area I want to focus on is about our schools-based service. What we've realised is that for many schools, they can struggle to kind of how they improve the mental health of their children. So therefore, Place to Be, we're going from 10 to 21 schools and primary schools in Wandsworth. Catch 22 is our main provider of secondary school-based counselling, and we're improving that. We're investing £90,000 next year on making sure we can extend that in our secondary schools. Because what we recognise is that children don't often want to be, parents don't want to take their children out of schools to go to counselling elsewhere. Although when we did a big survey of children, we asked where they wanted to go for children if they want to receive counselling, and in fact a lot of patients and children said, if it's 15-year-old, they want to go to their GP, because they said there is a bit of a still stigma when you walk into the counselling room in your secondary school. It's known where you're going, and so therefore when we're expanding Catch 22, at the moment they've got one community based in Latchmere, in Battersea. We're going to probably extend that as well into some primary school, primary care places, because that's where children have said they'd like to be seen. I mentioned the kind of targeted services as well. So that's a priority whereby we've got universal services, but we also know we need to target our services. And in fact, the paper identifies children looked after as an important group. And in fact, we've gone beyond what the paper has said. We do have a CAMS worker now dedicated for children looked after. At any one time, our local authority is the corporate parent for about 250 children who are looked after. They are often spread around the country. We've got to make sure they've got a very effective CAMS support worker, because they will often have significant mental health needs as they're placed in foster care and are being put up for adoption. We also are developing targeted workers in children at risk of sexual exploitation and children who have been sexually abused, because we recognise also that those children have got significant mental health needs, and that's a partnership approach with the local authority. Regarding our universal services, so what we recognise is the new access service is probably vital to provide universal services. Now any GP, any teacher can refer to our access service and can make sure that they're seen swiftly for an initial assessment. Previously they were bounced back, it's not eligible, it hasn't met the criteria. Now every single child is seen. But there's a challenge there as well. We've got now, I think, probably a very effective commissioning support unit mental health process. When we see any slippage in performance, the CSU now are on the trust very heavily. What we saw a few months ago was the waiting time for children going to Tier 3 breached our target of 80%. Therefore, we have worked with the trust and have issued a contract query notice to say this is unacceptable. You've got to address that. And in fact, yesterday I visited the CAMS service, went around, and I wanted to see what was the latest figure. I'm pleased to say to you now it's 84%, so we're back on target. ADHD and ASD are part of CAMS services. They're part of more wider South West London approach, which we agreed to. We've invested in those to make sure they've got a good service and they're nice compliant. We set the trust, though, a target which was an 8-week waiting time for first assessments for ASD and ADHD. Now, I'm aware that we've asked them to be nice compliant, which in fact is 12 weeks. Their average waiting time now is 11.7 weeks, so they are nice compliant, but are in breach of our local target, which is more strenuous at 8 weeks. Again, I went yesterday to the manager to ask why this was the case. And what's happened is the planned activity for this year has doubled. The reason we feel that has occurred is because there's a new way of assessing children who have got special needs, who previously would have required to be on a statement. Now it's called an education and healthcare plan. Many more parents, understandably, are using that process to identify their children who they feel may have ASD or may have ADHD. There's been a large media interest in this area, and many parents are concerned and therefore are referring into the service, and that's why the doubling of the referrals has meant that the waiting time isn't 8 weeks, it's 11.7 weeks. Again, that's a point of a contract query notice, but I want to reassure the board the service is still very much NICE compliant. The transformation plan for this year also focuses on eating disorders. That is commissioned principally for the inpatient services by NHS England, but we've been able to put in extra funding of 167,000 for this year and next year. The main benefits for that, I feel, for our local patients are firstly a waiting time of no more than 4 weeks. Secondly, that we're going to have a service which is based in the community. The evidence shows that avoiding an inpatient admission wherever possible is by far beneficial. And thirdly, I think which our community will really support is you can be self-referral into an eating disorder service by parents and children and by schools. Before, it's always gone through general practice as a gatekeeping service or mental health. We're developing a self-referral service. So I feel that hopefully I've shown to you that our plans to have a service which has got working on parenting, working on prevention, a school-based service, a school which has universal access, but commissioners are making sure when services fail to hit their targets, we'll be on them like a ton of bricks. It's something we're delivering for you. I just wanted to mention 16, 17 and beyond. So we've got this new money, this 591k, which we feel we want to invest in our services. We've listed our priority areas, which I mentioned to you today. I wanted to mention particularly a new priority area, which is transition. We've had many parents and young adults, often have got ADHD, ASD, have been under the CAM service many years, and then all of a sudden they're transferred at 18 and a half into, at the moment, a CMHT service, which looks after predominantly patients with severe depression, schizophrenia, bipolar illness. Those services don't really cater for those kind of children. The children are often out of education, which often gives them a great support. So we're going to develop for this year, and beyond, a transition service for 18 to 25-year-olds, which would be a bespoke service run, in fact, by, have to be an adult psychiatrist, because only they have got license to treat adults over 18, but focusing on that age group. We know also that the new EHC plans, in fact, run to 25. Right? We also know that if you're a child who's looked after in child in care, when you're 18 and a half and have left that foster care and on your own, you also need that kind of support. So therefore we feel this transition service of the local authority will be a vital service to make sure our children transition effectively, our most effective children transition effectively from childhood to adolescence to adulthood. And we hope that we'll have a nice compliant service within 2016-17. So they're our plans for next year, what we've done so far, and I hope that showcases how our team are working. Thank you very much.
Great, Tom, thank you. That's really helpful. And a really excellent report, actually. I think it's very well written and really kind of informative and easy to read. So thank you to everyone who's been involved in that. So shall we just have some questions and thoughts? Peter, want to start?
Yeah, thank you very much. To be honest, I haven't got any questions. Just a comment. Just listening to Tom's description of refashioning and targeting all the elements that he's described. I mean, the reality is that's going to make a difference. In 10 years' time, we'll have adults who would have been at risk of long-term enduring, so low, medium, high-level mental health disorder, who will be in a far better state. So the investment that has been talked about for a long time, not only in money, but in terms of restructuring and how you do things. And it's very hard to pick any holes in any of the elements of what's been described. So just a thank you.
Okay, can I add a hole which I forgot to add? Because I'm very good at picking holes. The thing which has happened recently, that the access service has moved from one side of the Springfield to the other side of Springfield into this new all-encompassing CAMS building. So one of my concerns is that, when they get lost in a wider CAMS service, and also they insist that all new assessments are done on site. So West Wandsworth and Battersea, I don't feel have a proper locally based access assessment service. Whilst you can have your ongoing counselling based at 166 Roehampton Lane, and in Battersea we're trying to get a place, maybe we're in a Catherine Lowe Centre, we're not quite sure. But the initial assessments are done on the Springfield site, which I'm still not very happy with. So that's what I would have said to myself.
Okay. Lucy, then Mike. Lucy.
So if there weren't going to be any questions, so I think one of the areas that probably I would want to highlight is the huge amount of work that has gone into an evidence-based approach to the spend. We have this new allocation of money, working with the local authority, and I think we have to credit very much Graham Markwell and the rest of the local authority team, Sean Dunkling and social services as well, working through John, to create the plan, which has been very well received by NHS England. But what we got was a full year money for the last 6 months of this year, so it contains a lot of pump priming money. And trying to get really good value out of that, I think, is a challenge in 15-16, and then making sure that we're spending exactly the same amount of money in the full year of 16-17 to do different things that build on that pump primed investment that we made in 15-16. So it's a fantastic opportunity. There was a real evidence base and a really good plan. The challenge now is to get all of the value out of it, because going forward we've got the same amount of money over double the time period, and we need to make sure all of the procurement, the metrics, the service delivery is in place, so we don't lose the great opportunity we've got.
Yeah. So Lucy, can I just follow on from that then? So what are the areas which are tricky that you think, hang on, we don't yet know how this is going to go in the future, given what we've done with the pump priming? Where's the risk?
So to try and answer that, so I was very careful that so I wanted to use the money this year on things which are genuinely non-recurrent, because people say, oh, you started that, so therefore we've done lots of evaluations, audits, or what we've done waiting list clearing services. So therefore, Catch-22, I've said to them, I want no adolescent on your waiting list, right? So clear it. And then same for the access service, I want you to get your waiting times down, so clear it. So that spends by non-recurrently. So therefore, we've got about £500,000. I've got about 5 projects, each about 100,000, right? Yeah, in a very simple way. So therefore, the transition service, I reckon it's going to cost us £100,000. So therefore, I spent nothing on it this year, and therefore I want to make sure I've got the £100,000 available for next year. The other thing is the parenting service. So therefore, developing a Wandsworth-wide approach. So we've got 2 parenting services at the moment, both got waiting lists, right? Which shows that as an issue is that therefore there'll be the 2 new things that we want to make sure that we fund appropriately: an extensive parenting service and the 18 to 25 transition service. And therefore, the other £300,000 will probably be spent on the recurrent spend. If you look in your grid, is the targeted workers, extending Catch-22, and then you're promoting resilience and robustness. There's kind of those first 5 projects.
Can I add to that? Because I think Tom's beautifully articulated our Wandsworth priorities. There is a separate element in this which is mandatory and is a South West London project, and that's community eating disorders. So we only have one provider. It's not something that is generally, there are a lot of providers in the marketplace. We're working with South West London and St George's. I think getting this new service set up with all of the challenges about finding the right kind of expert staffing, which we know are not widely available, and hitting the ground running, because we've got the money now and we have to start showing that we can really provide this new service for that completes a pathway for eating disorders, I think is going to be a significant challenge. But again, similar to Tom, I'm reassured that the new system we have in place of contracting around South West London and St George's means we have a single person who we can hold to account for making sure that all of that is delivered across all CCGs working with the provider.
Okay, great, thank you. Mike?
Thanks for a comment and a question. The comment first of all is, I suppose as a local GP and a clinician, I was just going to reflect that the service now available to our patients has been transformed over the last couple of years, and it is significantly improved. Many of us, and no doubt all the clinicians watching on live streaming, will also recognise that up to a couple of years ago it wasn't unusual to hear waiting times between 1 and 2 years to see care. So now, certainly the wait for first assessment has made a huge difference. Thank you very much. The question I was going to ask is, I'm aware that some areas in London have used or have approached their CCGs to use some of the money for infant mental health, so around the perinatal mental health, the mother-infant bonding part of that. I just wondered if you've been approached by any local providers to perhaps investigate that.
So we have had a discussion about that. In fact, we're fortunate in that at the same time we've got a perinatal mental health work stream anyway. And one of our providers of that very much focuses on mother-baby attachment. And so therefore the Chester Westminster support service to the Wandsworth patients is very much on the mother-baby attachment, and therefore we've given anyway £50,000 to that provider to get an extra worker to focus in fact on the other areas which are Battersea and Tooting for mother-baby attachments. So therefore we had the discussion, but in fact, because we'd already just funded them last year, I mean, they felt their service was appropriately resourced.
Thank you. Hardev?
Thank you very much. So really helpful context and really interesting information presented there. I think no one can deny the positive work that's been going on and the challenges that you're having to do with a rapid level of investment. So credit to you for that. My question is probably slightly is broader about the old problem about do you go by age or do you go by condition? And so when we talk about CAMS, it very much is about child, adolescent, mental health. And so there's a bit of age spectrum in there, and there's a bit of condition. And in the times that we're approaching where not just the local authority but the health spending is being really squeezed, are we doing as much as we can with the resources we have got, whether it's by condition or by age? So if I just expand on that, you mentioned eating disorders, you mentioned parenting, but at the same time, if you're targeting schools, are there other things that could be done, whether on a health aspect or social aspect, that we could be doing with that cohort, whether it is about conditions, not just mental health, but other forms? And should we be maximising the resources we spend on that cohort of children, whether it's... So you either go by... I'm not saying you either go by condition or by age, but you have got that dilemma here where you're narrowing down what you're going to be spending money on.
So I would answer that in two ways, and one actually giving it back to you as like dilemma. So we're moving towards a school-based service, right? And in fact, I would argue that in fact the new school nursing service, which the local authority have commissioned, and you could argue are a tier 2 service, right? So that, they've got, so tier 1 services are like GPs and teachers. Tier 2 service, are people who've got some sort of mental health training above and beyond that, which school nurses have. And you could argue is that are we underutilising that resource and investing in these specialist kind of, so you end up having a school-based obesity service, sexual health service, CAMS service, when in fact you've also got a school nursing service. And what you could say, right, is that do we just expand the school nursing service so we've got more school nurses with these generic skills who can do all this piece of work anyway? Now, and therefore we are, in my children's league generally, we are trying to do that, trying to have what's called a school offer. So every school knows they don't, the local authority now being in commission of health visiting, school nursing, joint commissioning of CAMS. So let's say, St Elsewhere School knows it's got this CCG at local authority say this is the service we're offering you, not 5 different kind of things. You could even kind of make that even more kind of generic and say, and rather than having 5 different people, we're going to have one person with many skills in order to consider it. The other side of the coin for that, unfortunately, is in primary schools, about 90% of Wandsworth children attend Wandsworth primary schools. For secondary schools, it's very different. We're a net importer of children into our secondary schools, but a lot of our Wandsworth children go to either non-Wandsworth secondary schools or private schools. So the problem with having a school-based service for children between 11 and 18 is that you're missing out a number of children who go to non-Wandsworth schools or the independent sector.
So that was really helpful and answers the question really well. I think the issue that the dilemma poses is something that clearly we need to think about, but it may be more about the targeted interventions that we look at to see those who are most vulnerable and the schools and the mix.
And it's always the issue about targeting universal. So we're doing both. So we've identified our top kind of targeted groups: children looked after, children in drugs and alcohol, children in gangs, children who are sexually exploited, and children in the youth and justice system. Therefore, that's where we put our targeted CAMS. Otherwise, we have a universal service plus an additional transition at one end and supporting parenting at the other. And that's our approach.
Okay, excellent. Thank you very much. Huda, do you want to carry on?
This is a hugely welcome report for 2 reasons. I've been comparing notes with other directors of public health around what they're observing around young people. Taking up drugs, smoking, and alcohol is coming down in young people from surveys done in schools. What is really becoming a big problem is the emotional well-being of young people, and cyberbullying and sexting, and this is really important. So and the other big problem is obesity. So these are like the kind of new priorities for young people. coupled in a way, and they are interrelated. An overweight, young person is also mentally affected by that, and also someone with an eating disorder. So my question to Tom is, with your guidance, Tom, and your observation, do you think we are being industrial scale enough around prevention? You talked about place to be and catch-22 being expanded. Given the scale of the issue, do you think we are being industrial scale enough, especially in a time when we're being squeezed on prevention money, particularly in local government?
We can never be enough, and Graham might come in and help me in this one as well, because Graham is probably leading on the school-based stuff. But so sometimes, some schools don't want as much help as others, and some schools we offer services to, and they feel they've got enough in-house. Sometimes they do have a lot in-house. I feel that we're probably not at the point whereby I can honestly say every single secondary school in Wandsworth has a comprehensive service which addresses the issues that you mentioned, and I think that would require a massive expansion. We're going to probably increase significantly, what we invest in catch-22, but I don't think that probably is as comprehensive as you or I would like. Graham,
Yeah, part of the investment is to look at a new universal programme, which is a curriculum programme, which is going into primary schools to work with children around their social and emotional learning, to enable them to be more emotionally literate, more aware of how to problem solve. And when we were facing this is a very evidence-based programme, as NHS England recognised. We were told the schools are already squeezed on their curriculum, they're having trouble delivering their core subjects, so be prepared to get a cold shoulder on this. But we went in 2 weeks ago and presented this programme, and we've already had 18 schools contact us to say that they're very interested in delivering this. The idea is that it makes the school, becomes part of the DNA, school ethos, as the years go by. And I'm extremely excited about it. For me, that is industrial scale, because we would want this to go across all of our primary schools over the next 5 years.
The issue, I think, of our probably not as effective is secondary schools, having an industrial approach to secondary schools. And I think the point you said about the increase in cyberbullying, emotional issues, while drug and alcohol is reducing. Our children now drink less than our adults.
Good thing. Yeah. Okay. Thank you, Graham.
Thank you, and just to add my appreciation for a really thorough and very helpful report. Thank you. Whilst I know it's not within our direct responsibilities, I just wanted to mention beds, because it would seem that it'd be incomplete to have a discussion about the CAM service without thinking about inpatient services as well, and bearing in mind that we have completed a consultation this year that included CAM's beds alongside the rest of the mental health estate. So our understanding is there is significant pressure on beds both across London and indeed nationally. So is that true locally, and what impact is that having on community-based services that might be picking up some of the immediate pressure that if people aren't being admitted? It may be that's out
because so beds are a tier 4 service commission of NHS England, and the big issue about the estate's consultation also was moving the excellent school we've got, which is linked to the beds on the Springfield site, potentially to the Tolworth site, and Kingston taking over the re-provision of that service from the Wandsworth Education Department. That's the ongoing issue yet to be resolved. I'm aware there are pressure on CAM's beds. I don't have the actual numbers, so I don't want to give you a figure which I can't be confident in. John, do you have any?
Just to say, Graham, we don't have the exact figures because the specialised commissioning NHSE have the tier 4 data. But what we've arranged as our CAMS partnership is that in the new year we would be meeting with them, because there are a range of other CAMS services which impact on beds. For example, CAMS outreach services, which are tier 3 plus, which could potentially have an impact in the community in terms of how many Wandsworth children go into inpatient beds. So we need to open up that dialogue with the specialised commissioning in the new year and really look at that, because I think that there could be commissioning arrangements in place whereby we get working in partnership with specialised commissioning, we get a more coherent strategy in terms of actually how do we prevent kids going in the first place. What can we do in the community with outreach services, for example, to reduce that. So.
Great. Thank you. So I've got time for just 2 more questions. So Seth and Jamie. Seth.
Yeah, thanks guys. It's a great report. I'm just really interested in how's it going to feel from the GP's perspective with the patient, the worried mother and the disturbed teenager in front of us. Because previously, as we all know, as GPs, it was very, very difficult to get help in that situation.
So now I would hope, there would be a number of options. So firstly, say the child also had another issue regarding drug and alcohol. Therefore you could refer to a drug and alcohol CAMHS worker. Secondly, if you felt it's a low-level issue which just requires counselling, you can now refer to Catch-22. Or you might say if they've got at the school that they may have a Catch-22 session based at the school. Or if you say, I want a more IAPT approach to the service, you can then refer to the access service. If you felt they also might have had an ADHD or an ASD component to their illness, you also refer to the access service and they'll get it sorted. If you felt they've got a real risk of self-harm or serious depression or even early signs of psychosis, you refer to the access service. So now I would hope you've got a whole array of opportunities to help that child and that family. Either access service for more specialised services, the school-based counselling, or more targeted if they've also got another ongoing need.
Excellent, thanks.
So, Tom, it strikes me, if you could just write that down and send it to all GPs, that would be really helpful. Jamie.
Thank you. 3 quick questions for Tom, if that's okay. First of all, it's really good the place to be is being expanded. I just wondered if you could remind us what the basis for selecting that the school would be to expand the service to them.
We've got 10 or 11 schools at the moment, okay, and the first 10 or 11 was self-selected in that they've got to make a contribution themselves to the service. Right? The reason it's very cost-effective is because Place to Be, in fact, have a professional supervisor and also trainees who are trained at University of East London kind of MSc course, and so therefore they're getting many hours in the school, and it's not necessarily very expensive. The next 10 schools we're selecting to, we're working with Sean Dunkling, so we don't want to go for an approach to say, who wants to do it? We're trying to find 10 schools which are in areas of greatest need. And so therefore we've got data on, kind of either deprivation, which we know links very carefully to children with mental health issues. And also the reason we want to expand Place to Be is because their interventions are not only effective, but we've found they also hit our target population. So they've got a higher than average proportion of children from black and ethnic minorities, which we know, in Wandsworth have high mental health need, whilst other services tend to, attract, a white middle class kind of worried well parent, whilst Place to Be do the exact opposite.
Going back to the contract failure, you mentioned some activity dumping. I just wondered if there were any other reasons for the failure, structural reasons.
Yeah. So for the access service, there is a slight structural issue. So before, what it was, people get bounced from tier 2 to tier 3. It's not my service. They're the wrong age, wrong size, wrong eye colour, right? And now everyone goes into the access service. They're seen, and then they're passed on to tier 3. So therefore, tier 3 are now getting less referrals now than they used to. So you'd think surely the tier 3 waiting list would be shorter, but now they've all got to have a tier 2 assessment first, which takes 2 or 3 weeks, and therefore the time the clock start for the referral isn't from when Tier 2 refers on to Tier 3, it's from ISGP referring to the Tier 2 service. So I have structurally built in an added 3-week process into the kind of pathway, which is why they often struggle to hit the 8-week maximum. But now they are hitting it, because we said by doing this, you'll get more appropriate referrals. And in fact, there's been a 25% reduction in Tier 3 referrals.
Okay. Finally, the transformation plan, I'm sure there was patient input into that, but it's not mentioned.
Okay, I'm going to hand to John because he coordinated that.
Yeah, and in fact, what we did, we actually had quite an extensive program of consulting with our children and young people across Wandsworth, and we had earlier in the year something called Momentum 2, which was a youth event across Wandsworth where all of the kind of decision makers in Wandsworth, across the key stakeholders, were invited to. And I think we had a huge cross-section of schools. One of the big issues was mental health, and we had forums where we could actually meet with the local children, and their vision for mental health services is fantastic. There's a lot that we learned from them in terms of what could actually help them. So that was part of the information that we put in our transformation plan. Attached to the transformation plan, there was also a detailed report from our participation lead, Laura Tyrrell, which outlines for the commissioners exactly what young people in Wandsworth think we should be doing in terms of designing services for them. So we see that as very central to the development of our transformation plan, that we really listen to what our children and young people want, because it's okay coming from a commissioning perspective, but our perspective is limited. We really need the children, we need their families to inform us how to design services.
Excellent. Done, thank you. Anybody in the audience would like to ask any questions on this item? No? Okay, thank you. So just to sum up then, I think thanks very much for your presentation and your report. I think it's safe to say that the board is really proud of the work that you're doing. We really, really support you in what you're doing. And we really welcome the focus on parents and schools and all the work that's going on for children and families in Wandsworth. It's really critical for the future in this borough. And also the success that you've had as recognition of this as being a good plan by NHS England, which, that's important for us as a board as well. So thank you all for everything you've done. Our job today is to just note the progress against the strategic objectives in the CAM strategy and your transformation plans, which I think that we have done, and to approve these proposals for the local priorities that you've identified for the 15-16 spend at this stage. So are we happy to approve that financial spend? Yeah. Very good. Thank you very much, all of you. Cheers. So, what have we got now? We've got finance now. So, Neil and Hardev, I imagine.
Yes.
Hardev, you're going to kick off? I
will do, yes. So, this is a finance report, and it's always a great pleasure to have a focus on finance in the run-up to Christmas. And I'm sure Neil will be bearing many gifts in his in the presentation. But what I'm sure will come out from the discussion is, for the current financial year, while we still aim to hit our financial target, it is becoming increasingly more challenging, and that has a consequent impact going into 16-17, where we will notice a significant difference in our financial approach and our financial flexibility. So I'm sure Neil will start setting the scene regarding how difficult, how challenging times will become going into 16-17.
Thank you, Harder. I'll do my best to get that message over. So I'm referring to attachment 3 here, and basically in 2 parts. So the first part being the month 7 financial position, and then moving into the second part, which is looking forward to 16-17. So in terms of the month 7 financial position, just looking at slide 3 in terms of the financial scorecard, just some points to note on here from changes from previous months. We've had the comprehensive spending review, and I will go into a little more detail on that later on in the presentation. We're still expecting the planning guidance and allocations to come out in December and January. In terms of financial governance, the Finance Committee have started looking at and reviewing our financial planning for 16-17. And in terms of financial performance and financial risk, continuing care, or the contracting around continuing care, is currently being reviewed. So moving to month 7 and some of the key messages. So we are, as Hardev says, expecting to achieve our planned surplus of 4.2. However, there are areas of significant overperformance, mainly around continuing care. Acute contracting continues to be a problem, and prescribing. So there aren't any new areas that have emerged from the last finance presentation, but just to note that it is an increasingly tight situation. Slide 5 really just highlights it just for information, but we've had a couple of allocations that have come in relating mainly to specialised commissioning services, which are transferring to the CCG and be our responsibility moving forward. Slide 6 looks at the overall financial position, so really just reinforces those key headlines that I mentioned earlier. But I'll move into a little more detail on each of those areas now. So in terms of slide 7 and 8 and 9, this talks about the acute contracting service. So there's a bit of detail within the slide, so I won't go into that detail again. But just to note that actually, even though it is overperforming, it's probably not quite to the same level that we've seen in previous years. So, so in effect, that is good news. However, there are pockets of overperformance, mainly relating to the elective orthopaedic centre, which we know what that issue is in terms of activity transferring from St George's. More concern is Kingston Foundation Trust. There has been quite a significant shift in emergency activity this year. That's something that the host CCG has picked up, and there has been a contract query notice just to understand what exactly the issues are around there. Across all the other contracts, basically they're pretty much spread out. St George's at the moment is around about 300,000 over, which only represents about 0.3% of their overall contract. Just looking at acute generally across the piece, so some headlines here. A&E activity overall, we have actually seen a reduction, mainly around the routine A&E attendances. However, we have seen an increase in the case mix, which in a way we probably would expect in terms of our quick programme targeting and removing some of that routine A&E activities. We have seen some increases around planned care, and in particular day cases around scoping procedures, and that is at St George's. And we've also seen some shifts from outpatient attendances into procedures as well, mainly around dermatology, and again that one is at St George's. So just moving on, looking at the non-acute position, as I've mentioned earlier, the adult continuing care continues to be a problem. We're forecasting around about 2.2 million. However, just to note, we are doing sort of reviews around that number just to ensure that our forecasting is as accurate as it should be. In terms of mental health placements, we've got some pressure around there as well. AQP services, mainly relating to acute physio and non-obstetric ultrasound scans, is another area. What we're checking for there is, has there been any diversions out of acute activity into those areas? So we're just looking at that at the moment. And prescribing has continued at the same rate, so we've not uprated this forecast. This is in line with what we forecast earlier on this year, and no reason for that to change, but it's still significantly above. Slide 12, given continuing care has been mentioned a few times, I thought it would be useful just to really have a look at and set the context for continuing care for the last 4 years. And we can see that actually there's been a 43% increase in continuing care expenditure from 2012-13. So looking at this year and comparing it to last year, you're probably seeing the least amount of shift than we've seen over the previous years, but it's still significant and clearly showing that whilst it may be slowing down, it still represents a problem. So slide 13 looks, or is just tabulating all the financial risks that I've mentioned, and I think we've not really added anything else onto there than what was there previously. For running costs, well, performance against running costs and QIP, we're still on target to achieve. What I would just want to mention around QIP is that whilst there are some areas that haven't achieved the QIP, there are some of the other schemes that actually have overachieved, and in particular the diagnostic has been successful, because there is a significant underperformance in the St George's acute contract. So that's something that has been a successful scheme. For slides 16 to 19, this really just looking at the balance sheet and cash flow forecast, and there isn't anything I particularly want to pick out other than on slide 19 against the better payments practice, just to flag that against our statutory obligation to achieve payment of 95% of our invoices, we are actually achieving that. Although it does flag that within our non-NHS invoices that we are slightly below the target, but overall we are achieving. So that sort of concludes the 15-16 position. I'm just going to pause there and see whether anybody's got any questions around that.
Carol, then Lucy.
Yes, on slide 14, which is the running costs, patient and public involvement is shown as having no expenditure, which strikes me as slightly unusual.
Yes, I will need to just double check that that's probably been consumed within another line, unless Hardev has got.
I suspect it's more about the definition. So we followed the guidance around running costs, and I suspect this is more about what's defined within running costs and what's defined as non-running costs.
So just so I understand that, so that means if you've got lots of PPI work going on, but all the input into that is through the project management support, which has been in the proposals, it wouldn't come under running costs. Would that be right?
Yeah.
Yeah. Okay.
So
it's not meaning we're not doing anything; we're just spending it in a different way. Okay, that's okay. Peter. Sorry. No, go on. Carry on now. You've started. Sorry, Liz.
Clinically led.
Yeah.
One of the challenges for us is that a 43% increase. Does that relate to local need? Is it entirely relevant to the nature of the population, the shifts in the population complexity, or is it just an increase on our specific population?
I can start. So I'm sure if Tom was here, he would comment on the expectation that there is a likelihood of greater need, and I'm sure probably Lucy's probably just as equipped to answer that.
I missed the service that Peter was describing, which
Continuing healthcare.
It was continuing healthcare. So I think it's a very complex picture, and we are doing a significant piece of work both within the CCG and across South West London to understand in more detail the drivers for the increased spend, and therefore the different ways that we might look to mitigate that both this year and going into next year. Some of it is about the population, so we know we have an increase in frail older populations when we look at the two Wandsworth greater population of older people living in deprivation on their own, and so on. That lends itself towards hospital admission and then continuing healthcare. We equally have a second and significant area of continuing healthcare, which is in profound and complex disability, which is both neurorehabilitation and following trauma and lifelong disability, which is different to our colleagues in South West London. But I think there is another issue that we're looking very closely at, which is the performance of the provider of continuing healthcare service, and whether enhanced performance in terms of undertaking timely assessments, undertaking timely reviews, and ensuring that the process of continuing healthcare is done to the highest possible standard, whether if we had a higher performing provider in place, that would also change some of the spend profile. So that's where we're placing a lot of our emphasis at the moment.
Okay. Do you want to roll on then?
Oh yes, my question. So it was just looking at slide 5 and the line at the bottom about the transfer from specialised commissioning. So I know that there's been a long and drawn out saga about the services that are changing between NHS specialised commissioning and this coming with CCG. But I think we've been waiting a long time to understand exactly what money came with the activity, and so that's good to see that there is now, I think that's £1.5 million for neurology outpatients and specialised wheelchair. I just wondered what sort of risk assessment we were doing in year about whether we think the funding matches the spend we're going to be liable for, and then what learning that is for 16-17, where we know new and more expensive services like bariatric surgery are likely to come to us.
So currently, it's not getting charged actually to us, so we've had the allocation in, but nothing's come through in any of the reports as yet. So at this point in time, we haven't got a view on that, but we should be getting charged for that next. So I know it's not in month 8, but it should be there for month 9, and therefore we need to be assessing that.
So we've got the money, but we don't know how much spend there is against it yet.
Right,
so it could be anything. So I suppose that's my question: how do we assess the level of risk? We in fact have luckily a meeting this afternoon with the technical reference group, where we might be able to press some of that if we need to.
And that is part of the answer. So there is finance groups and other groups that are set up who are aware and know the splits in terms of actuals versus plan based on historic performance, and I've been doing the risk assessment behind this, and as yet they're yet to share the findings of that with their colleagues. So I'm sure in your group and in the CFO groups that will start to come out.
Okay, Huda.
Different question. Do we understand the reasons for the overperformance of prescribing or the overspend on prescribing? Do we have numbers?
Yeah, so it's sort of twofold. So there is the growth that we put into the budget originally was not sufficient, so that was one of the contributing factors. And the other one was a national pricing issue that seems to have affected all CCGs as well. In addition, there was some antibiotic prescribing as well. There were additional costs that came through for that, which should have benefits in terms of outpatient attendance appointments in acute. So you wouldn't necessarily see that as an offsetting source against that particular budget, but that also is one of the reasons.
Okay, do you want to move on then to the next section now?
Okay, so just in terms of the comprehensive spending review, that came out earlier this month, last month. So overall, there's been confirmation that £8 million has been agreed to the end of 2021, and effectively 5.3 billion of that front-loaded for the first 2 years. So that does give health economies an opportunity to address financial sustainability moving forward. There's also the increase in additional funding for mental health in terms of the talking therapies as well. However, because of the no protection for social care, that does represent a risk for acute providers, just in terms of the potential delayed discharges. Also, we got confirmation that Better Care Fund was continuing along its the levels that we're currently committing within our budgets. So just moving on to slide 22 around the timetable. So we should be getting applications notified to us this month. and in terms of the planning guidance as well, should be coming out in 2016. This timetable really just takes us through to the board signing off the budgets in April 2016. But I think given that the late submission of the planning guidance, that does represent quite a challenge for us to have robust and accurate budgets for the board to sign off in April. So I think I would just want to make that point around this timetable. So looking forward into 2016-17, the issues that we've got this year, clearly moving forward into 16-17, so continuing care until we get a view on exactly the reasons behind that, and are we, on top of that. So the review of contracting will play a part in that as well. Prescribing cost pressures, so will we see similar issues to what we've seen this year? And we need to be as well informed as we can be, because I think we didn't factor in the fact that we've got this pricing increase nationally, so it's what indicators do we need to be looking at to ensure that we don't get caught out with that again. Acute contracts continuing to overperform, it's obviously an area we continually see, so whilst the level of overperformance is not as high this year as in previous years, clearly our ability and the quick plan really does rely on keeping control of acute contracting. And also we've been doing a review of all the recurrent or all the non-recurrent investments that we've made this year, ensuring that it's actually delivering exactly what we need it to deliver. So if it's linked to a saving, that we are actually making that saving. So moving into 16-17, as mentioned in the timetable, it's likely to be because of the late notification of the guidance, it's going to make it much more complex. We're going to have a very short time scale to turn things around. We know we have our host being a challenged organisation, that's clearly going to complicate discussions as well. We're assuming we're going to get minimal level of growth this year, so it'll be interesting to see what our share of the comprehensive spending review actually is. But that will also be linked to any of the discussion around the planning guidance, so tariff. So potentially there's a risk there that whilst we'll get minimal growth, that we will actually have or have to pay more over to our acute providers to address some of their issues. So there's a risk around that. The QIP ask is going to be significant for next year, really to address and ensure that some of these issues that we are creating the headroom for the organisation. So we're setting a QIP plan in the region of 13 to 15 million this year, so it's 9 million in 15-16, 13 to 15 million in 16-17. That still is around about 3 to 3.5% of the overall allocation. And there is also the risk around if we decide to go with primary care delegation, so any pressure that may come with that allocation, that we will have to address that shortfall as well. So slide 24 really just looks at the draft business rules. So again, this is just a rollover of this year's business rules. The one thing I will point out in here is that we want to create an investment reserve to set aside for QIP. So obviously setting a large QIP and giving us that headroom, hopefully it enables us to have an investment reserve that then means that we can continue to invest in those areas that are the key priorities for the CCG. I'm talking about QIP in 16-17, so we're in the process of identifying that. We've got a meeting this week, a key meeting this week, which will look at what that potential gap is at the moment. Which at the moment I've said within the plan for next year 14.5 million, so I've sort of hardened that QIP target up now. So that's the target that we need to ensure that we have a balanced position moving forward. We've got a series of meetings, as I mentioned. We've also met and had a more targeted discussion with each of the commissioning programmes to go through what additional stretch we can apply to existing schemes, any new schemes that we need to look at, and really just a general review of the areas that we're currently investing in. So my final slide here really is just taking the financial risk contained within the board assurance framework and linking them really to the issues that we've potentially got for next year and how we may be looking to mitigate those. So the first risk there is allocation is less than expected. So we're taking a conservative view on growth, low growth into there to mitigate against that. As noted there, we're not clear at the moment how primary care growth will be calculated if indeed we do take on that delegation. In terms of financial pressures across the South West London economy, we do have a risk pool that we contribute to, and this will help us to mitigate against any unknown risk. Within the collaborative programme as well, we're continuing to work with providers working towards having a sustainable health economy with improved quality and health outcomes. Financial distress of the main provider, so we're continuing to work. We have a monthly meeting around their recovery plan, so we will be doing what we can to support them in that. And in terms of delivering a balanced financial plan, so at the moment it's the QIP that is it's a huge QIP that we've got in there. That's the challenge that we've got in terms of delivering that plan, and that we can deliver our surplus. And again, just to make that note about the late issuing of guidance does mean that having accurate budgets is a real concern. So if there are any surprises in the acute contracting by the time we get to agree that, we need that sooner rather than later. So I'd like the board really just to know the contents within this report, but in particular know the financial position as at October 2015, I should say, not 2016. And noting any identified risks going into 16-17, the importance of QIP plans for 16-17 to deliver financial sustainability, the anticipated low level of growth in allocation for 16-17, and the late issuing of planning guidance and impact on the contract round.
Okay, Neil, thank you very much for those gifts. So, questions and thoughts on that? Peter, yeah.
Sorry, can I dive in? There was one line on the first page of that, the spending review update, which was public health. That's what I'm getting before who did that, which is seriously concerning. So the way you've written it is it's against the prevention agenda. But actually a really large part of the review is prevention. And I'm just wondering how we're going to, we talked about gaps and holes through the morning so far. How we're going to deal with that. I don't know who the ones to follow that on.
Thank you for raising this on my behalf. I was thinking, shall I raise it or not? Actually, yes, as you know, the public health grant has been reduced, and I don't know if it's appropriate to say this in a public meeting, but I've heard a colleague say, the principal is robbing Duncan to pay Simon. This is how it's kind of like been, but it is. It's just a figure of speech, but the funding has reduced in the public health spend, and it is challenging, and we will need to look at only work within the budgets that we have, and as you know, the local authority is even pressured more on a number of other fronts. So I think these are conversations that we need to have initially offline, maybe management, directors with the local authority, and see how we are going to address that. You're absolutely right to raise this, Peter. It is very important.
I'll visit on that.
Yeah. And I'm sure Lucy has a point to raise as well. It's just we recognise, as was highlighted in here, the impact of those reductions. We also recognise that we've got a reduced level of growth in the CCG. We also have a completely challenged main provider. It's the ingredients of a very challenged health economy that needs all parties to work together on this to understand its priorities and what can work, because unfortunately there will be some aspects where we can't afford to keep doing all the aspects that we're currently doing.
So it's a similar point, but in a wider context. I think through our work on commissioning programmes, and there being a prevention and wellbeing programme which is now further in development for 16-17, beautifully exemplified, I think, by the CAMS paper, which shows how much investment we are putting into prevention, because we all know that's the right thing to do. We will be caught in this very difficult position of wanting to invest in prevention because that's the right thing to do to get the right outcomes for the people of Wandsworth, and significant commitments in the acute sector or with providers already, and then as Harlow's already said, our very challenged major local provider. So I think what Neil's paper helpfully does is outline the challenge that we need to start sharing more publicly, because there will be more difficult decisions this year than we've had to take in the past, because the squeeze is you're not going to see the benefits from that investment in prevention in time to stop the pain for providers when some money has to come out. And that's the bit where 16-17 is going to feel very different and is going to hurt, and this is the start, I think, of our communication with the wider population as we take that forward.
Yeah, I agree. Carol?
Just echoing what Lucy has said, I think involving the public is really important on this, and also could help to contribute to the prevention agenda by involving more of the voluntary sector, the third sector as it's called now. There are lots of organizations around doing things in this area, in a whole range of things: nutrition, healthy eating, mobility and balance and things like that, that could really contribute to the agenda. But we have to make sure that there's a lot of public engagement on this, and there hasn't been sufficient so far.
So I'm thinking as well clinical engagement, really, because if we need to change how we spend our money and we're facing decisions about that, then it needs to be clinically led. We want to make sure that we're doing that in a way that's, really evidence-based as much as it can be, and that we engage our GP membership in this as well. So we need to be going out and talking to GPs about, and I know you already have in localities been starting to talk about this, but as it firms up in terms of what the size of the challenge really is, then I think that's really important. So we'll work on how to do that between us in our clinical leads meetings. Yeah. Stephen?
I mean, obviously we don't know the actual numbers, and we won't know until Christmas or after Christmas, but I guess at this stage we ought to be assuming the worst, as it were. Yeah. And I wondered whether we know enough about how other CCGs, which have already been facing much more stringent financial pressures than we have in recent years, have been responding. I mean, if we were Croydon, we'd say, it's just another year of this, and I, in terms of what has worked or what hasn't worked, whether we need to be talking to those who've been through this kind of pressure in a way that Wandsworth really hasn't for some years.
So
I think
that's a really helpful steer, and we'll do that. Certainly from our discussions with the likes of Croydon and others, there are a number of areas of services that we take part in, and initiatives and investments that we've made that Croydon and others have not. And I think it's those type of areas where some of those are now going to be brought into question. The other aspect is actually they're focusing quite a lot on being able to develop long-term savings plans on a big scale. And while we've done that certainly for the last 2 years running, I think we're at the point now where we need to re-energise that process of having much more robust, large-scale savings programs. And that's, for me, is the bit that's missing at this stage.
Can I just slightly shift the emphasis of that, though, because there's this money that's going to be front-loaded now, so that's going to come into the system in some way. It's likely to come with a transformation banner on it, isn't it? So really, I think we have to do everything we can to be more efficient as an organisation, and to do all the evidence-based things which are good quality but have shown to save money, and that's really important. But it's obvious that we have to do some things differently, and so understanding what it is that we are doing on that front, and we have got transformation plans in a variety of areas, but probably probably a more comprehensive view of it, so that when this money is available, we're ready to say, hang on, we've got a really good plan here, we need to have this funded. And that works for Wandsworth and the South West London approach, of course. So, you know, we can't just keep doing what we're doing but spend less money doing it. There's a limit to what you can do with efficiencies, isn't there? So I think the transformation thing's really important.
Yeah.
Peter?
Yeah, good. To add another point, obviously, is my self-management hat on. So, and we had a bit of a discussion yesterday around personalisation. That one element, and so it's partly what I was saying, but it's not just the engagement bit, is actually creating capable populations.
Yeah.
So if we're really going to, you know, we're going to, obviously 16, 17 is going to be very challenging. But the investment in populations who can themselves cope with that challenge and the effect it has. And it's not to say that self-management then says people self-care. No, it just means that people actually have a much more targeted and managed way of managing their lives. And that in itself, I mean, the evidence at scale, if you look at the evidence around the world, and particularly around Stanford, etc., it would show that if you do that at scale, more capable population. I mean, sort of leaning towards Malik a bit, you know, investing in the communities that Malik talked about as well. Actually, then the challenge is shared, and people are sort of doing their own thing around that. So.
In order to be able to invest, we then have to do something else differently or not at all in order to do that. So our QUIP programme is really, really important. That's the key to unlocking all of this. So that's where our efforts need to go certainly in the short term, isn't it? Anything else from anyone to flag? Anything anyone would like to ask members of the public? Okay, thank you very much, Neil. Thank you for that. Wade through an enormous amount of stuff. That's really helpful. Thank you. So we're noting the report. Really, there isn't any decision to be made on it. So we're headed to Battersea now. Nick, do you want to sit at the front? So this is every year we have each of our localities present the work that they've been doing and their plans for the future work. And so is this the first time you've done this? Well, excellent. So that's
really
good. And Emma, this is the first time you've done it as Battersea, although you have kind of shifted around the borough now. So that's very cool. So excellent. Do you want to kick off and flag highlights?
First, we are relatively new to Battersea. So I'm Nikki Williams, GP at Battersea Rise, so in the southern part of Battersea, and I do the role jointly with Jonathan, who sadly can't be here today, who sits in the northern part of Battersea, and then Emma, who was in West Wandsworth, is our management lead supporting us. So I'm going to assume you've read the paper, so I'm not going to go through line to line. So basically Battersea is made up of 12 practices, and we range from 1,500 patients to 14,000 patients. And one of the big things that the three of us have been doing over the last year since we've arrived, is introducing ourselves, but also trying to engage these practices as much as possible. And one thing we have done is the two least involved practices we have gone and visited, had meetings with, to discuss issues, why they're not engaging, and actually they now are engaging much more. We're getting a lot more feedback from the practices as to what's working and what isn't working, and hopefully they do feel much more engaged with what's going on in the CCG, and that their views are being listened to and they are being supported in these difficult times. So in Battersea as a whole, we currently have 95,000 patients, but one of the big challenges we have coming in Battersea is we're likely to have a rise of between 26 to 30,000 extra patients in the next 10 to 15 years, mainly driven by the 9 Elms and Vauxhall development. So I myself sit on the project board for that, looking at the healthcare needs along with public health and the Lambeth GPs of that new population that we have. So currently, we in Battersea have the most deprived ward, Lakshmi Award, in the whole of Wandsworth, but we also have the least deprived ward in Wandsworth, which is Northcote Ward. So we recognise that these two populations share some health priorities, but actually there are different needs for the different populations. So one of the big engagements we've done is with public health, looking at what the needs of Battersea are. And if you look at the public health needs of Battersea, One of the big things is, at least in children, that it's bright red across Battersea. It's the highest in Wandsworth, and 3 of our wards sit right at the top. So that's in both reception and year 6. We also in Battersea have 4 times the diagnosed prevalence of HIV than the average in Wandsworth, so 2% versus 0.5%. We have 30% of our households are in receipt of means tested benefits. And then we can go on, you know, the high levels of under 75 deaths from cancer compared to the rest of the borough, higher levels of emergency admissions for COPD, higher levels of cardiovascular disease. And then the other one which we've identified as a new priority for us is we have a higher percentage of domestic violence and the highest prevalence of FGM in the whole borough as well. So we've identified that as some priorities for us. So that's what we're going to be working on in the next year, is how we engage to deal with these to improve the outcomes for our patients. We talked about members. We've also have a very active patient group, and in fact the chair of our members forum is also the chair of our patient group. Sadly she couldn't be here today, but she wanted to make very clear that as a patient group they feel that all the local projects in Battersea have all been developed and amended following consultation with them. They've also they attend our members forum and feel very much that it's open to questions from them. They also feel that all issues that the patients of Battersea raise are followed up and addressed promptly. We've started engaging with some of our third sector who have approached us around our key priorities and how we can work together to deliver them. We've also very much this year started to think about the fact that Battersea sits with 3 main providers actually, and St George's doesn't provide all of our secondary care. So we've improved the links with Chelsea and Westminster, and Jonathan Chapel now sits, and we have much more oversight on quality issues and what's going on at Chelsea and Westminster as well. And we started to do the same for Guy's and St Thomas's. And we now have a Battersea GP, interestingly, sitting on the Council of Governors at Chelsea and Westminster to represent Battersea's needs. I'm now going to hand over to Emma, who's going to discuss the projects that we've done this year and something on the future projects.
Yeah, thank you. So, obviously, following on from what Nikki said, there have been a number of areas we've been working on this year with our practices. So we started off with a project, a 2-season HIV project around sexual health. So we worked with public health to deliver this, and they also did an evaluation for us of the outcomes. So we provided all our practices with training around HIV rapid testing, chlamydia testing and condoms. We worked with Terence Higgins Trust and Public Health to do that. So during the year, practices were looking to increase their testing around HIV and chlamydia, and throughout the year HIV rapid testing increased 88% in our practices from Q1 to Q4, with 2 reactive samples identified, and practices also carried out nearly 780 chlamydia tests with 30 positive tests identified. And the practices found that through this training and this work that they did, they've increased their awareness and knowledge, and they've been able to embed this learning within their day-to-day work around sexual health. We've also developed a mental health project delivering mindfulness courses to our population. So these are courses delivered within Battersea. The GPs can just refer their patients directly to. So so far we've run 13 courses with 260 people attending. We carry out an evaluation, so a pre-course questionnaire and a post-course questionnaire with them. And of those people who attended, 88% have reported that following the course they were confident in their ability to deal with stress, compared to just 20% prior to them attending the course. And 79% reported their stress levels impacted less significantly on their lives following the course, whereas before the course 91% said the stress did have a significant impact on their lives. So we're continuing to deliver these courses to our population. And we've had some very positive feedback from the patients who've attended as well. The other courses that we're running are some parenting courses. So as Tom mentioned earlier around this, so we've so far run 7 courses with 43 new mothers attending. So these are focused at new mothers with under ones. And the course is a 5-week course, covers a number of areas such as infant first aid, baby massage, feeding, physio, and we work with the neighbourhood midwives to deliver this course. Again, we've been evaluating it, doing pre and post course questionnaires, and 95% of those who attended said they benefited from the course, and 55% strongly agreed that following the course they felt more confident in their approach to parenting compared with just 19% before the course. So we're continuing to run these courses, but we are currently reviewing the content just to ensure that they are appropriate for our population, and that we're reaching the patients that would benefit the most from this. And we will link in with CAMS to make sure we're working with them as well, following their presentation earlier. So there are another few areas that we've worked on. We asked our practices to do some work around cancer early diagnosis, so carrying out a number of significant event reviews that the practices reviewed 46 cases and peer reviewed them in their practices. They're currently all of these, so this was done across all 3 localities, and Cancer Research UK are currently reviewing all the cases that were evaluated to pull together the learning from that for us. All our practices within Battersea have signed up and engaged with our Members Development Programme, working on a variety of quality improvement areas, and 5 of our practices have so far had visits from our practice support team, and we've got the rest of those to be completed in the next few months to look at areas that we can support the practices in improving. Battersea also contributed to the dementia and IAPT targets around increasing local diagnosis rate for dementia and increasing IAPT referrals. Yeah, so these are projects that we've already been working on. We've got a number of new projects that we're just starting. So some of them are working with public health again. So we know that our childhood immunisations rates aren't as high as they could be. So we've been working with public health to pilot their birthday card scheme, whereas they produce birthday cards that the practices are sending out to their 3, 4 and 5-year-olds as they come up to their birthday to remind them and their parents about their upcoming or outstanding immunisations. We've only just started this for course of 3, but we're already seeing health reports that this is just having an impact and is increasing the number of parents bringing their children in for their immunisations. So there'll be a full evaluation at the end of the pilot. We've also, Nikki was already mentioned about our Battersea issues with obesity, and we know that our reception in Year 6 are particularly areas of issues. So we are following on from the project that was started in Wandsworth. We're trying to identify those children before they start school. So we're asking our practice nurses to weigh and measure the children when they come in for their preschool boosters, and we've been providing training for them to make sure that's done in the right way, that they're using the right charts to identify the weight and measures, and how to have the conversations with parents if their child is overweight. So that again is a project we're just starting. Our third big project that we're just about to start is our patient welfare advice service. So we know that a lot of the issues that patients come to the practice with aren't necessarily clinical. They may be around housing or benefits or other social advice that they need. So we've been working with Citizens Advice, DASCAS and Family Action to set up a service where GPs can refer to that, and they will be seen, triaged and seen by the most appropriate out of those 3 services to provide advice. So we'll be piloting that with them starting in the new year. Yeah.
Very good. Excellent. Thank you very much. That's all really, really interesting stuff, and a nice report as well. I thought it was really great. I'm going to look at Huda in a minute because I want to know if it's outcomes based enough for you. I'll let you think about that for a second. Anybody have any questions or comments on that? Huda.
This is probably a question for Nikki on a more general issue. I was struck in here and in the presentation you talked about that IAP service and how certainly back in the 14-15 you were able to increase the referrals that supported the delivery of the target. Do you think targets in general, where GP colleagues influence that is better done at a locality level than at a CCG level. And so what are the key drivers? I'm just saying, so if at the moment we're having issues around IF again, then is there something, what would you recommend is the best channel to do?
Well, I think if things come from we have our members forums where we have a captive audience of all the practices, and I think if it's delivered locally, the importance of it, I think the message is driven home much better than if it's a CCG-wide message that tends to be diluted down as it comes down the chain. We also can contribute making sure our mindfulness courses contribute to the IHAP standards as well, so making sure those.
And are those messages consistent between localities, or are they?
I think so, yes.
Thank you.
Okay, Stephen.
Childhood obesity. I wanted, is anybody looking, it may be for Huda rather than, I mean, is anybody looking at this Daily Mile thing, which is great claims have been made for, and I believe in Scotland they are looking at it in a more systematic way. But it's, you know, it is presented as being, you know, in near magic pill territory on childhood obesity.
We're also working, we've done meetings with public health on the healthy weight pathway for children and how what the information we are getting we can feed into that.
Okay, so I have two questions. One about the outcomes. So start with the Sterling. It's a Sterling, isn't it? And they got children to run a mile before school.
Oh, I still, not Daily Mail.
Mile.
No, Daily Mile. Okay, so I mean, definitely this is something that's absolutely the type of thing we should be doing. It's cheap, it's cost effective, and it has showed results. And I've raised with at the moment the team are really so working with schools around their lunch boxes, and so it hasn't been done yet, but certainly on the agenda. We're going to go to Sterling, or at least connect with Sterling to see how they have done it. I already have been approached by a local, we talked earlier around assets in the community. There is a local organization called Living Streets, or kind of South, and they approach you, how can we as a civic society help you kind of like promote kind of the physical activity, etc. And I mentioned Sterling to them this, and they are also be very keen to work with us. This doesn't only look at what happens in the school, but also are there any environmental changes around the school that need to happen in order to allow them to run. So this is something that is exciting. We're considering it. I can't tell you we have done it, but it's certainly being considered very seriously. Regarding the outcomes, absolutely a huge improvement from previous reports, and I really welcome that. And and the really good thing is that you are thinking, everyone is thinking evaluation from the very start, because the worst situation to be is when something has been done, go and evaluate. You haven't baselined, you haven't agreed the outcomes. The issue that I will always, and I'm probably Hardy would have asked this. You take the example of the people who are taking up the mental health, the mindfulness, etc. Are we reaching the class that we want to reach? Is it like the white middle class, kind of like affluent and North people that you mentioned, or is it the people who are really more needing it? So are we getting the granularity from the outcomes around this differential uptake? But it's a huge improvement, and it's really, really good. I'm really happy with reading the report. Thank you.
Okay, great. Mike.
So answer the question around the kind of the granularity, the uptake of the services by.
I think we can look at difficult to know from an individual patient point of view, but if we look at the uptake from the different practices, it would suggest that it actually is. And interestingly enough, it sits in North Battersea where the most deprived wards are, rather than down in South Battersea with the least deprived. So it requires the least deprived to travel up to the most deprived wards in order to access it. So it suggests it does.
I was going to introduce an element of gentle challenge to our public health colleague. I think you're suggesting that mental health needs are more really in relation to people who are deprived. Certainly, speaking to Battersea colleagues, I was going to ask Nikki perhaps to comment on mental health need in white middle class people.
Massive mental health need, and it's also one of the things we've identified with the NEV is that we will have a young, potentially fairly affluent population, but one of their biggest needs is mental health and stress, and low-grade depression is very high.
sorry if I misled I didn't mean that people do not have mental health needs, but also you need to make sure that the people from, what you don't want is to increase the inequalities. It just address the mental health needs of people who are, affluent, who definitely have mental health needs need to be addressed. Tom actually mentioned this earlier in his ethnic minorities are overrepresented in
serious
acute and underrepresented in the preventative and tier 1s and tier 2. And this is really what I was trying to say. But nowhere was underestimating the impact of mental health in any person, regardless of their class.
Yeah. Okay. Anything else? No. Excellent. Well, thank you very much, guys. Well done for your first one. That was fantastic. But it's really good to hear what you're doing. And so, as a board, what we're doing is to note the progress that you've made already in your achievements, and just approve the future. Bibi, do you mind? Sorry. Do you mean? Sorry, I'm just in the middle of summarising. Thank you. Have a seat. You get an opportunity to ask questions at the end. We're heading into a coffee break now, so. So we're approving the ongoing and future priorities of Battersea locality. So full steam ahead, I think, is what we're saying. So thank you very much. Okay, shall we just have 5 minutes or so break and stretch before we move on to the estate strategy? Thank you.
So I thought my husband was. I thought you met one of his
estate strategy. Item 7.1. So, Andy, you're going to introduce, and Kate's here as well. Yeah.
Yep. So I'd like to welcome Kate back to the board in a slightly different role, and this is actually called an estate strategic framework. The reason being that this apparently was the last estate strategy produced in Wandsworth.
And that looks glorious.
Which is a 200-page document from March 2012. Has anyone ever heard of it or read it, or has it been implemented?
Sad enough.
It's probably Graham that put it in the bottom of a cupboard. But that reading that document really served as a lesson, I think, for me and for us about how we actually use our clinical strategy to drive our estate strategy, rather than just to sort of look at builders and think about what could be done, but not really relating to the clinical strategy. So this strategic framework is really on the back of lessons learned from that, but also around a letter we had, every CCG had over the summer from the Department of Health, which was around making sure that we are clear about what our need for our estate is going forwards and what our current estate is. As you can imagine, there's an awful lot of work that hasn't been reported to the board, which is around some very specific sites, and obviously that was taken to be commercially and confidential, which is why the board hasn't received all that information today. But what this is really a route map that will sort of set out some of the key principles about how we might start to develop what's called an implementation plan. And that implementation plan that we're developing behind the scenes with an estate strategy working group, which is chaired by Kimball Bailey, one of our associate lay members, and includes representation from NHS Property Services and NHS England. We'll be looking at some very site-specific information over the next few weeks. That will then form the basis of what's called a primary care transformation fund, which is again a new initiative across the country over the next 4 years. So by the end of February, we have to have signed off a primary care transformation fund, where we'll put in there, if you like, requests for capital work around whether it's knocking down walls to create additional consultation space, looking at how we can really start to pump prime some of our MCP hubs, which we talked about in our board previously, and looking at all the digital technology that comes with that. We'll have to put this bid together by the end of February. That will then go off and go through the processes at NHS England. But essentially, in order to do that, we needed to have set out as our board some kind of strategic framework or a route map that sets out really the direction of travel that we're going in. And as I said, there is an awful lot of work behind the scenes that's going on in terms of the implementation plan. So what does it look like on a very site-specific level? How can we maximise the estate that we've got? How can we look at, for example, Queen Mary's Hospital and have a proper strategy around utilising that, and also be very conversant to opportunities around the Roehampton regeneration, and also NEB, which is obviously subject to regular board updates as well. So this is a paper that we've sort of put together. We tried to keep it as brief as possible, as I said, learning from lessons in the past. It is obviously just a point in time where we're at now that just sets out the principles, and we would certainly expect throughout 2016 to come back to the board, hopefully to report on a successful primary care transformation fund and how that's really going to meet our estate's requirements for our clinical strategy and the development of the MCP. That's it from me. Do you want?
we've got nothing to add. Okay, great.
So we're here today to seek approval on this paper and also to note the work around the next data implementation plan as well.
Okay. Jolly good, thank you. So, what would you like to talk about? Lucy?
So thank you, and it's nice that it's a much shorter document than the giant one you were just showing
Very
us.
much so.
I suppose my question is the phrase implementation plan a requirement, or is what you're talking about a prioritisation list? Because in the absence of understanding what funding is available, I was unsure of how we'd be describing the full implementation plan. Well, can you describe a bit more about what the aspiration is?
I think it's both. So I think there are probably one or two things we can do without having an awful lot more money, which is around perhaps using opportunities as we're looking at around Doddington to look at a state with the local authority and say, right, actually we've got a bit, you've got a bit, how can we make a collectively kind of a bigger bit together that doesn't require, if you like, pump priming using this transformation fund. But clearly there are a lot of things that we might want to do that require more money, and obviously that money's got to come from somewhere, and we don't have it as a CCG, but there is this primary care transformation fund, which is really sort of a national picture and particularly very important for London, given the fact that the estate isn't really fit for purpose anywhere, to really for us to prioritise what we would want to put as part of that. So I think it's both. I think it's about saying in the next 2 months, what is it that we need to put in that primary care transformation fund that said these are our priorities going forward that we need the money for, and in parallel with that, what are the other things that we can do as a CCG working with local stakeholders where we can get better use out of what we've already got.
Okay. Peter?
Can I follow that through? So just to really stress the point I think you made, Andy, is that so within one particular fund to do something major is going to be quite challenging. So, and following around our MCP model, we're looking to develop facilities or places that have multi-use, and if they've got multi-use, that means that you could theoretically use multiple budgets to then fund that sort of development. So it might be worth looking at all sources of estates development funding to sort of pull that together.
Okay. Howard?
Just trying to bring some of that together, really. So this local framework then feeds into South West London Estates framework, which will be produced by the end of March. And that starts to bring together the South West London strategy and should include position statements regarding providers, and that expectation is at least a position statement regarding local authority and other public sector bodies within the South West London. So then you begin to get a whole South West London picture of the estates and what the estates would look like. And the expectation is that eventually those decisions around estates are made at a strategic planning group level, and therefore you could assume that the funding is devolved at a strategic planning group level for all capital and estates across all those organisations. But we're still quite away from that, so this is just one of those phases that you go through to get there.
I should have said the high level is the SRO for estates across South West London Strategic Planning Group.
Yeah, okay. Stephen, did you? Yeah.
I suppose my question is about the timetable. I mean, I had no problems with the framework as it stands, but equally it didn't. I think my reaction was be slightly surprised it didn't move it forward further than it actually did, because it stated lots of things we kind of know. And then on the next steps, which is section 9, it lists a whole pile of things, which is sort of really the financial stuff, site stuff, which is the real nitty-gritty and meat of the thing. And I suppose my question is, are we going to be able to do all this stuff between now and the end of March, and then integrate it with broader South West London stuff and things like St George's have big estate issues, etc., etc. So, the timetable seems challenging, shall we say?
I'll let Hardy touch on that bit, and then I'll talk about some of this local specific stuff.
Thank you. So the real answer is going to be no. Clearly not. I think what we've got to do is be realistic behind this. So any strategy whether it's estates or any other aspect, is at a point in time, and that's what this is trying to demonstrate. What we need to accept to begin with is when the CCG was developed, estates function was devolved out, and therefore within the CCG itself we don't have that skill set. And what we have got is Katie, who's done a remarkable job trying to pull all this together, who's actually not trained to do this. And so we are now in the process of bringing those skills through NHS Property Services and others together. And so it's going to take longer than we would like. Having said that, we also need to make sure those organisations such as acute hospitals who have got that expertise already built in, we need to be working with them to understand the impact across all of South West London. So I suspect what you'll see in March is again a similar point in time with a direction of travel where South West London would want to get to, and this is before any form of potential consultation or anything like that. So a long way to go, and we won't have all the answers by March, but we'll certainly have a clearer picture of what the intention is going forward.
I think what pins it together locally is our estates working group. So actually when I read that document from nearly 4 years ago, I went through it and I thought, that hasn't happened, I didn't even know about that one. But it's been really important. We've only been meeting since I think July, to actually get the key people around the table and start to gather that information and then start to be able to inform it. So we've been able to inform developments around Brocklebank, opportunities around Doddington, several lease issues that some are still outstanding, but some we now know about and taking forward as well. But then through this, try and set it in the context of actually our clinical strategy is this. We then need to try and put the estates approach behind that as well. I think that estates working group with the additional resources that Hardo mentioned, will actually try and bring it together between what's the strategy and actually making sure that we are delivering it, and it doesn't just become another document or a suite of documents that sits on the shelf and don't get implemented.
Is this a follow-on?
It is, yes. I mean, I understand all that, and I do recall very vividly, the mess that this whole area was, and so I entirely buy all that. As in, my question then follow-up is in terms of our capability. I entirely understand we are not estate specialists, we haven't, it's all that, and cost, because this is quite a big exercise potentially, and so sort of, are we biting off, it's a bit like sort of primary care commissioning, hang on a minute, before we just jump in, have we got the capacity, have we got the funding, the resources to do this? I mean, I'm not quite, haven't got a sense of that.
So do you want me to answer that?
Let's keep going with this.
So on the actual funding, as I said, we don't clearly have the resources or the capacity within the organisation. What we have been able to do, though, is draw down funds on a London level to support the delivery aspect behind it. So the reason why we've been able to produce this paper is because we were able to access funding at London level, and we'll continue to do so. And I strongly push the argument for South West London that we don't have that capacity, and given what's going on in South West London, we need more resources. And so that argument is being put forward, and on a weekly basis I get drips of money coming down, so hopefully we will get that support going forward, and it's likely to be in the form of the Primary Care Transformation Fund to help CCGs implement a number of these issues.
Lucy, on this,
it was just related to that and Hardev's earlier answer. So just to check my own understanding, when the Primary Care Transformation Fund is considered at an SPG level, is there the potential then for all of the money to be used in a CCG that has a greater level of need than Wandsworth, or is there going to be, do you think, a different prioritisation system?
To be discussed and agreed. I suspect there's nothing, you won't find anything written down that says the intention is to do that. I suspect where this is heading, if you look, this goes back to the London Mayor's report about maximising estates, and the case really for devolution, and I suspect this is going to be one of those areas where we would want to test out, are we able to make those types of decisions at a strategic planning group level, in which case you would need a formal estates committee of some form with all relevant parties on board. And as I said, we're quite away from that.
Quickly on. And the Primary Care Transformation Fund replaces, for the last 2 years, what has been a Primary Care Infrastructure Fund, I believe. which was down to every single practice to bid for. They got part of the money but had to pay for a lot of it themselves and had to complete the work in a very short time frame as well. So not surprisingly, actually there hasn't been a particularly big success. But one of the reasons behind this new approach is to try and do it over a longer period to make sure you get the maximum gain. So it's not just about knocking the ball down, it's about doing bigger and better things, and also to make sure that in a CCG and at an SPG level it's far more coordinated than just one or two practices saying, yeah, we can do this, we can do that, and 40 odd practices not doing anything at all.
Graham.
So it all links through actually. So 2 points. So I'd absolutely echo what Stephen said. I think I'd really like to see what the implementation work and programme looks like into 2016, because it's not really reflected here at all. So I think we need to be clear on when it will come back and what key milestones are for decisions. And then on the latter point about being ready for whatever process around the transformation fund, there's not enough of detail, particularly around the primary care estate in here, that would tell me we will be in a position to possibly fight our corner for actually some of that investment into Wandsworth. So, you know, it maybe it's just not in the report, but what's the degree of our understanding about, for example, the fitness for purpose and the quality of existing primary care estate out there, and where would we look to say we would wish to prioritise any opportunity for investment into next year? This is a short-term piece as well as a longer term strategy. So
it's not about actually in terms of the resource. So we've already had a piece of work that's been looking at individual premises and looking at their utilisation, their compliance against CQC, their demographics around are they in an area with predicted growth, etc. And it's about, I think, doing a bit more deep dive work on that and linking it into our MCP, where we say we've actually set some priorities here that if there's a premises that's perhaps falling down and only serves 1,000 or 2,000 people, you wouldn't perhaps invest in that. But you would look at opportunities perhaps around whether it's around Green Mary's or our MCP for hubs that we've said we want to really try and bring forward as well. So I think it's about revising that work very quickly early in the new year that then gives us a very accurate, realistic in terms of what can be delivered and how much it might likely to cost in terms of, we then prioritise that for our primary care transformation fund, make sure sitting alongside that we've got an implementation plan where we know we can perhaps leverage some of the expertise that there is in property services along with what we want and what we want from our own clinical strategy to try and make it work and bring it together. It is an ongoing journey, but I think the work we've done literally in the last 4 or 5 months has probably brought us on further than we have been in the last 4 or 5 years to get to a position where we now say, actually, we think we've got a route map going forwards.
Okay. Mike.
Thanks, Andy. I think this is a really good starting point as a strategy document. So first of all, just to restate the obvious declaration of interest, I'm a GP partner in a practice that provides services in Wandsworth. I suppose I sort of reflect the complexity of this. So at the moment we don't commission primary care, but we do commission services delivered by primary care and in primary care. So the document gives a fair bit of detail about the 14 premises that are PropCo owned or LIFT or PFI. As soon as on the assumption that we do go to delegated primary care commissioning, we will then inherit a whole different layer of complexity with the 41 practices operating out of a number of different sites that are operating under a different variety of contractual vehicles. So, for instance, my practice has 3 sites in Wandsworth, 1 of which we own and 2 which we lease. I suppose I'm just flagging that this document will absolutely need to be iterative and it will need to develop as we think about not only the services we currently commission to be delivered in the premises of primary care, but also as we start to think strategically about where there's more need, perhaps for new practices, or thinking around some of the developments, perhaps where there's less need for practices or need maybe for aggregation of sites. The reason I mention this now is that I think to the majority of the public and also to our member practices, when we talk about estates, they and the public will naturally think of the most frequent contact with health, which is in primary care, I suppose. So I'm just aware that when this document goes out, if it is read by primary care member practices of the CCG, I guess they might be looking for a little bit more detail about perhaps the strategy around the primary care premises.
Yeah, and I think you said it is a point in time. I think we were very careful not to mention specific practices, perhaps by name, because then you might say, well, why have those been chosen, favoured over others, etc. But clearly we'll have to have those discussions at some point fairly soon. But we didn't want to really load this document with a lot of perhaps potentially subjective material that then kind of shies away from the main point about developing that route map going forward. And just to flag, this is not about just a that does not so practices will have an ownership or co-ownership of property services. This is about all of the primary care estates in Wandsworth, out of hospital estate.
Thanks, that's very welcome clarification.
So just, I'm sort of sensing a degree of kind of acceptance that we're in a difficult place, and that this is a useful thing to, I suppose, surface this conversation really. But still a bit of anxiety about what's to come. And if you think about it, there's no wonder we're in this position, because that document down there was written at a time when actually they didn't know what the fallout was going to be from the Health and Social Care Act. But I do think there'll be an awful lot in there that actually hasn't changed since then. So some GP practices will still be in exactly the same situation that we were with the list of problems, and we mustn't lose that. Yeah. So we mustn't lose the value of that. Please let us not do that again, except to just check in and see if that's the case. So I think that's important, because this could be a huge piece of work. But I do think that going forward, this either needs a phenomenal collaborative effort or some really good governance to make some decisions in this, because at the moment the reason it's not happening is because NHS England and NHS Property Services and CCGs don't know who has to make decisions on all of this. And so, Hardiv, I'm looking to you, you're holding this together. But it's really important that we are put in a position where we can make decisions in the right way.
Yeah, so I think there's a few things there. So firstly, as a CCG, I've heard each CCG present their position statement of where they are, and one's is about slightly ahead of the pack, but everyone's there or thereabouts. There are some which are still finding their feet, and those tend to be the smaller organisations. So you can see we're starting from quite a low base across South West London. I would say that the information contained in this report, there's actually quite a lot more information behind this, which is the bit that Andy's referring to. Yeah. And so some of the questions that Graham and Stephen were certainly posing, we actually have quite a bit of that already. And the bits that we haven't, we literally over the last few weeks have gone at risk, financial risk, to get hold of that information, knowing that we will get some funding nationally. So we're trying to pull this together. I also sit on the London group, and what we're experiencing is replicated across every borough in London. There isn't one borough that's cracked this yet, and we're expecting by the time we get to March that there'll be a number of position statements and direction of travel, and what the push is for is to see if you can at least by March start scoping the governance arrangements of what that potentially could look like. And so that's probably where I'm heading on this is, do we know what that would look like, which is really what you're asking as well. Have we got those mechanisms in place? And we're seeing what's happening with the primary care delegation around joint committees, etc. You can see where this may end up, so it does need a lot of careful consideration. And you put in the mixed local authority, any public body in South West London, and it can be quite enormous. Yeah. So I'm happy to keep certainly management team informed on how we're developing this. I suspect between now and March it'll be more about position statements.
Yeah. So, Jamie, you're waiting.
Yeah, thank you. Mike mentioned the public, first person to mention the public, and if I could just draw your attention to paragraph 1.7, which says, in order to realise the benefits, CCG will consult with other public sector partners. It'd be really good to add in the public, ensure the public has a part of doing this.
And I think that then ties into wider conversations around primary care. So if you're looking at perhaps something to do with an estate that's very significant, that's then likely to impact the practice, and obviously then there is that whole process that goes with that around engagement and consultation as well.
Yeah, okay, Stephen.
A very particular question I just wanted, if you could say a bit more about, is Queen Mary's, which you obviously flag here. And it obviously looks like one of the a very big question, and one that's very specific to us, as it were. It's not a South West London thing so much. And can you just remind me, I probably also know the answer, but I don't, what the timetable is for the Mental Health Trust to make its decision about whether or not it is going to move? I mean, because that obviously sets off a whole chain of options or non-options.
So the position as consulted on would see the Mental Health Trust vacate their wards at Queen Mary's in 2019. It's conditional on the new Tolworth development.
But when would the decision be made?
So the decision in principle has been made as the outcome of the consultation. So they're busy working on the business case that needs to support that. But in principle, that timeline was set out in the consultation.
But they haven't...
To be ratified through a business case process.
Yes, that's the point.
Yeah.
So when is that ratification? Is that
during next
imminent?
year? It will have to be, yeah.
Right.
Yeah, to deliver that in 2019.
Okay. Okay, very good. Anything else to raise? No. Anything from members of the public on this paper? No. Okay. Thank you. So clearly this is very, very important, isn't it? It underpins so much of our primary care transformation and our out of hospital strategy, and there are some big financial issues in there, and Queen Mary's is one of those. So we're going to be seeing more and more of this. So it's really good to get us all up to speed on that. So we're approving this as a strategic framework, which is sort of as we are now, and the next steps really, and authorising the production of an estates implementation plan. So I think we just have to go forward into that, and things will emerge as we go on. So are we happy with that? Yeah. Okay. Thank you very much. Thanks, Andy, and Kate for all the work you've done on that. Keep going, Kate. So, London Delegation Agreement. Graham, are you going to
I will,
just
and
talk about
to give
this?
it its full title, it's the London Health and Care Collaboration Agreement. So you have a copy of the proposed wording of the agreement in the papers, just to briefly introduce this. So over recent months, partner organisations in London, and indeed in common with similar discussions happening elsewhere in the country, have been considering how as part of the preparation for and response to the comprehensive spending review, we could demonstrate the opportunity and the benefits of taking forward a new approach to collaboration, and the possibility of devolved powers and resources moving across the system, either centrally to London or from across London down into local level in different ways, and how those powers and opportunities could be used to further improve collaborative work to support improved health and wellbeing outcomes for local people. So this paper presents the proposed agreement that has been drafted on behalf of all the CCGs in London, councils across London, NHS England, the London region, the Mayor, and Public Health England to enhance collaborative working. And it sets out a set of arrangements which actually are certainly on the NHS side, very familiar to us and already in place in terms of 3 different levels of collaborative working. So founded on the local, which is about the CCG working with the local council and other local partners. Sub-regional, which in our language is South West London and the strategic planning group area, and then obviously pan-London, and of course we are already engaged in a number of programmes of work across the capital now, particularly through the Healthy London partnership. So really this agreement is aiming to set in place a programme of governance and a joint approach to underpin each of those levels of collaborative working. The agreement is heavily based on a set of principles and aspirations. I think reading it would be difficult to argue with many of the principles built into the design of the agreement. And again, its foundation is very much based on all of the output and the work of the London Health Commission and what has then flowed into programmes of work across London. But it's really trying to create a more formal framework under which that work is taken forward. Part of the agreement proposal is to initiate and to support a small number of pilots in London to really test out different options, different ways of taking forward a kind of different style of collaboration, and potentially to test some of the boundaries around devolving resources across and between different levels of authority. I can report to the board that none of those pilots are proposed to come from South West London at this moment in time, and certainly we're not seeking to exploit that immediately within Wandsworth at all. But what is requested of us is that we would, if you like, provide general support to those pilots, and clearly a willingness to take on board any learning from that in future years, and think about how the learning might be applied more locally into future years. An earlier draft of this was circulated to board members, and thank you to those of you that fed back comments. This is the latest version that we have. It is making its way around all CCG governing bodies, and as of last night, we are one of only two who haven't yet had the opportunity to consider it and hopefully sign it off. And I also believe that all local authorities have now, in principle, agreed to endorse and support it. So that's its current position. So the board are invited to both consider the agreement and hopefully agree your support for it. Thank you.
Very good, thank you. Carol, would you like to kick off?
You say it's been to all the CCGs except two. Have they all accepted
They
it
have.
without question?
They have, yes.
Thank you.
Make real trouble. It's an opportunity.
Yeah. Anything? All happy?
Yeah.
Good in principle. As you say, it's quite difficult to argue with it.
Aspirational.
So,
Can I ask
yeah.
a sort of nitpicking point?
Yeah.
The regional is the SPG as far as we're concerned.
So the region is London, sub-regional
Sorry.
is the SPG.
Okay, sorry. Yeah, whatever.
Yeah.
Is Surrey Downs part of that?
No. So we'll probably come on to
yes.
that
paper.
in the next paper. So the SPG is South West London, but for the purposes of the programme around transformation, reconfiguration that we'll come on to talk about, that is including Surrey Downs, but they are part of a Surrey strategic planning group area.
And that doesn't cause any... we have to have duplicate governance for these two different purposes.
So it's a recognition that the SPG is wider than the programme of work that we're engaged in that involves Surrey Downs. So there will undoubtedly be some boundary issues to manage through over time. But the SPG will... So, for example, this work, as set out here, includes all of the Healthy London programmes, which don't necessarily all interrelate with the South West London programme of work, which otherwise involves Surrey Downs. I can recognise the degree of confusion and or the risk that some boundaries become a bit blurred.
I can understand the distinction. I'm just wondering in practice whether or not it means when whoever it is gathers together wearing a South West London stroke SPG stroke whatever hat, this process of work needs some different people or governance arrangements or meetings or all that stuff, because it's not...
So yes, it does, and it already happened actually. There are still a number of places where we meet as South West London, and then there are other places where we meet with the inclusion of Surrey Downs and indeed NHS England and the other partners who are engaged in the programme of work we'll come on and talk about shortly.
It's not a neat, tidy world, is it?
Minimise bureaucracy is what
Yes.
really lies behind this.
Yes. Okay. But in general, we're happy to approve this approach.
Yeah.
Jolly good. Thank you. So now we'll go on to the with some overlapping areas, but the South West London and Surrey Downs Health Partnership.
Yeah. Okay, so you have a suite of documents that were provided in the pack. I would suggest we look at the slide deck. It's probably the best summary, just to quickly work our way through. So the papers describe a new revised approach for the management of the 5-year strategy that has been across South West London but is now proposed to include Surrey Downs CCG because of the particular relationship and the involvement of Epsom and St Helier Trust in this programme. So if you look at slide 3, the background, this will be very familiar to members of the board, but clearly for the last 18 months or so we have been working together with colleagues across South West London on a single collaborative commissioning programme. We published the Case for Change and a strategy last autumn. And in parallel with that, acute providers across South West London and more recently out of hospital providers have been coming together to work in collaborative arrangements as well in support of the strategic direction. We have been undertaking a review of those arrangements earlier in the year, and you will be aware that there was an application from South West London to join the successfully National Success Regime programme, which wasn't ultimately taken forward, but it did provoke the review and consideration of what was an appropriate set of programme arrangements going forward. And that's where the proposal for Surrey Downs to re-enter the joint working arrangements, and indeed for a much more explicit sponsorship, I suppose is the word, of NHS England, Monitor and the TDA to support the work across South West London became more explicit and has led to some review of the overall governance arrangements. So on to slide 2, just describes some of the work that has been happening to realign this as a single programme of work. It is fundamentally still based on the case for change and the strategy that we did agree last year across South West London, but again with some partner organisations joining us now at this stage. So there will fundamentally be a refreshed, renewed approach to the overall programme management. It will include the support of an independent chair who has just been appointed, and that's covered on slide 5. So Sir Andrew Morris, who's the Chief Executive, I want to call it Frimley Park, but it's actually Frimley Health now, Foundation Trust, has just agreed to fill the role of independent chair. And other key roles around senior responsible officer and programme director are currently being recruited too. As I just mentioned, there is a more explicit role for NHS England, the TDA and Monitor to support this work, and there is a slide, and indeed there's a more explanatory paper in the pack about actually what their roles are under statute in support of this programme. But fundamentally it's still at the decision making, if you like, around the programme and taking forward the work rests with the 7 CCGs together with NHS England as a commissioner. And the overall programme governance approach is summarised on slide 7. So at its heart are really 2 groups, and you've got the detail in the pack around the terms of reference. One is a clinical board, so there is a very clear, renewed approach of this being about clinical leadership and clinical direction at its heart of the programme, supported by a programme board which is a group of feels like many hundreds when you're all around the table, but a significant group of people from across commissioning, provider and other organisations who will steer the programme overall, reporting up to governing bodies such as ours for formal decision making. So the request of the board is obviously to note the proposed arrangements and indeed endorse them in terms of the governance and the approach going forward. Thank you.
Thank you, Graham. Okay, so do you want to delve into this a bit then? So Stephen, does it do anything to at least clarify what the problems might be?
No, I understand this. I'm just sort of trying to work out.
Yes.
I mean, my personal reaction to this was actually I thought this was quite clever as a way of trying to overcome the inherent difficulties of getting people across South West London to work effectively together. Mm-hmm. And what I basically read is that the supervisory bodies, the 3 of them, plus the chair, will put pressure effectively on all the players to line up behind whatever it is that emerges from the actual substantive work. And that's probably what we, to be honest, in South West London do need.
Needed, yes, I agree.
There is quite a complex governance setup, and mention is made in relation to the 3 boards of representatives of patients or the public as required. The Patient and Public Engagement Steering Group of the South West London Commissioning Collaborative, great initials, is putting forward a proposal for the first programme board with suggestions of how this might be met. And it includes Health Watch representative and somebody from the PPEG on each of the 3 boards as an initial starter to ensure that there's involvement from the very beginning. This has to be agreed by the programme board, but I think it's quite a sensible proposal to ensure that there is engagement from the beginning.
It's just joined us.
Okay. Okay. Hello. We're just talking about the paper. So you've got two different things on the agenda. It's the first one.
Right. Yes.
Delegate. So we've just gone through the presentation part of it. So, so thank you, Carol. Anything else, Stephen?
Could you just confirm whether there's any change in this about our responsibilities as a CCG in relation to the hosting of the team, and what is our role domestically in this setup?
So it's unchanged as things stand. Though to be fair, we haven't had an onward discussion about whether or not that should be reviewed in the context of this. But here and now, it remains the same, and there's been no proposal that that would rest with any other CCG currently.
Okay.
So can I,
yeah, keep going.
I mean, the other big question, obviously, about all this is whatever comes out of this process is the stakeholder engagement.
Yeah.
I think, I can't remember, that there's some local authority involvement, but I think from memory it's not as though every local authority is going to have a seat at this vast assembly, probably sensibly. So they're so engagement with local authorities is going to be really big issue. It also struck me that, for example, even the providers, the chief executives are there, but if you were, for the sake of argument, chair of a foundation trust with no seat at this table, you and your other directors would feel just a little bit sensitive, shall we say. So I think the engagement with the stakeholder, even within the NHS, leave alone the outside, is going to be quite a significant process, and that's before you get to the public across this vast area and so on. So I mean, we all know this, and you know it, but the stakeholder engagement dimension is going to be huge, and I do think this structure does seem, as I say, quite a step forward in terms of getting the organisations within the NHS into line, but that doesn't solve some of the wider challenges ahead.
So I think it's absolutely acknowledged that that's work ahead, and a lot to be clarified there in the paper. It explicitly says it isn't aiming to set out all the stakeholder management arrangements. That is to come. But just on the specific point about local authority representation, there is one seat on the programme board, and that's currently Simon Williams.
So there are two seats in local authorities, because there's Simon Williams, who's representing South West London, and then there'll be a representative from Surrey Downs, Surrey County Council. As well, and there is a local authority reference group which has all of the representatives on it who will meet in advance of the programme board, so their collective views can then be brought by this.
Where is Simon Williams from?
Merton.
And also, just to acknowledge the difficulty even within the stakeholders that are represented within this group. So at the clinical board, for example, we had a meeting last week, and it was raised that the medical directors of the acute trusts are there talking from a clinical point of view, agreeing the clinical models, which may have implications for their organisation, and that's very difficult for them. And so that's another thing, issue that we've got to address, the dynamics in all of this.
Sorry, a big one.
Carol.
Do we have a timeline for this? As in over the next year, over the next 3 weeks, over the next 17 centuries?
In terms of the implementation of the arrangements. So it has already started, at least in shadow form, prior to all the CCGs and the other agencies adopting it formally.
An end date?
So I think we're one of the last CCGs, I would consider this formally.
Richmond will be the last CCG governing body to discuss this, which is on the 19th of January. And then the first formal programme board will meet probably in the first week of February. We're just managing diaries on that at the moment.
Okay, Stephen.
Well, also on timetable, this goes beyond this paper, I appreciate, but the actual programme itself, the substance of all this, as distinct from the governance of it. What can you say about where we are and when actual specific propositions would actually start to be presented to this governance through process, and when will CCGs get feedback on that and be asked or consulted at some stage, hopefully before final decisions are made?
I'm so glad Kay arrived.
So there's two elements. So it's part of, there is a 5-year strategy, and we're in sort of going into halfway through that 5-year strategy now. But within that, there is some potential major service change elements which would require consultation, should that be the case. So the run up to that is that by March next year, we should have got some clinical service models designed around some of the acute areas and a level of ambition for the out-of-hospital strategy agreed, building that into a whole system model for April, May next year. And I spoke with the Clinical Senate last week around their strategic sense check on that, which would be around that sort of time, leading through to consultation, should we need it, around November next year. I mean, I won't be held to exactly November, but it would probably be sort of around this time next year we would be expecting to be in consultation.
So that could open the possibility of, as it were, what I always think of as emerging findings to be discussed with CCGs and others in the summer.
Oh, certainly by that point, absolutely, yes. Yes, I would have thought sort of late spring, early summer. And all of this, until we've actually seen what those groups come up with, we don't know sort of whether or not we would need to consult on it. But I think it's likely that we will.
Okay, good, thank you.